Dr. Awofisoye, over to you.
Okay. You need to allow me to share screen, sir. Hello?
Hello, yes, I'm hearing you.
Okay, you need to allow me to share screen.
I think you can do that already.
Okay, showing all.
Okay.
Yeah.
Okay, go ahead. Okay, go ahead.
Thank you very much. Good afternoon, everybody. My name is Dr. Awofisoye O. This afternoon, we'll be talking about insulin therapy in diabetes mellitus. And like Dr. Isako introduced earlier, insulin is something that we all must have had to use at some point or the other in the past. And quite often, it can be tricky sometimes. Let me just put it like that. But today, I think I want to talk about it, and we'll discuss different parts of it. And hopefully, at the end of the discussion, we'll all be able to be more confident in using insulin the right way and more confidently. So I'll try to go with this outline. So we all know that the prevalence of diabetes is increasing, and up to 50% of people with diabetes are not adequately controlled. The data for this 50% is from Ibadan, and that's even in a specialist center. You can try to imagine what will be going on in among primary care providers. We know that defect in insulin secretion or action is central to diabetes itself, and therefore it's no surprise that insulin therapy is a key component of diabetes care. And in fact, everybody that takes care of people with diabetes has to be familiar with at least some aspects of insulin therapy. Even though the discovery of insulin actually revolutionized diabetes care almost a century ago, we know that there are still huge treatment gaps, especially relating to the use of insulin. And I think that 50% not being adequately controlled just testifies to that. We know that diabetes is as old as man, and even as early as 2,500 years before Christ, there has been accounts of descriptions of diabetes. And the truth is that before insulin was discovered, diabetes was literally a life sentence. The initial treatments used to be practical starvation, that they rid the individual almost entirely of calories. But despite that, the person continued to wait to get leaner, polyuric, and eventually died of the ailment. It's actually, people have actually wondered whether starvation was the cause of death for most of the early people that died of diabetes, because they literally took them off every calorie. And we see that sometimes even in these days in which people will have diabetes and there's actually a need for treatment intensification. But rather than intensifying treatments because of either the fear of going to insulin or some other things, the person tries to starve him or herself the more, which of course usually will not work. When insulin was being discovered, initial experiments were done with the pancreas by removing pancreas from animals like dogs, and they saw that these animals developed diabetes, which gave the information that this is likely the source of what causes diabetes. But it was until 1922 when Banting and Best actually were able to get the insulin out of the pancreas. That was actually when it was the evidence that this compound is the compound that is missing or that is not working well among people with diabetes. And they were able to purify it to some extent and use it to treat initially the dog with diabetes, and then later on the Canadian boy with diabetes that we are all aware of the story. Of course, we know that initial insulin was produced from cow and pig pancreas, literally from the abattoir. It was literally mushed up, and then the insulin was extracted from it, okay, before human recombinant insulin, another type of insulin that we currently use now, were being produced. We go through the bit of the physiology of insulin secretion because understanding this physiology is actually key in understanding insulin therapy. We know that when we are treating someone for diabetes, we're trying to restore them from a pathological state to as much as possible a physiological state. So it's good to just get a physiological background a bit. We know that beta cells form about over half of the cells in the highlights. We also have alpha cells that produce glucagon and many other cells in the pancreas. Insulin is initially produced as pre-proinsulin, which is converted in the endoplasmic reticulum to proinsulin, okay, which is then cleaved into both insulin and C-peptide. And that has some diagnostic utility. We know that insulin and C-peptide is produced in roughly equimolar amounts. So if you want to know how much, if you want to have an idea of insulin secretion in a person, you can either measure insulin or C-peptide, knowing that they're usually produced in the same amounts. Because it takes time before insulin is produced, it actually needs to be stored in the pancreas, and it's usually released when there is some stimulus for its production, and it's released by exocytosis. It's also important, looking at this diagram that I have, looking at this diagram that I have in the right side of the screen, to know this graph. Insulin secretion, the natural insulin secretion is in about two phases. There's a first spike, which is rapid, happens early, and surges high. But there's a second spike, a second surge, which is much gentler but more sustained, okay? Early in diabetes, this first phase is actually the first to be lost, okay? And if there's a pattern you can see in OGTT, that you know that this person has lost the first phase insulin secretion, and that's what happened in the very early phase of type 2 diabetes. Of course, we know that insulin secretion is regulated both by nutrients and also neurally, okay? And we can see in this chart, basically diets, glucose, but not just glucose, also amino acids, which we often tend to forget as doctors. And so nutrients, glucose, amino acid, and of course the neural components, both in form of epinephrine, that's adrenaline, which is a counter-regulatory hormone, and neural input from the central nervous system. All of this leads to increments in insulin secretion. And because the pancreas does not just produce insulin, it also produces glucagon, okay? But when these stimulus are there, then we have more insulin relatively to glucagon being produced, and the effect of the insulin supersedes. The opposite happens actually when there is relatively low amount of nutrients in the blood, or there's relative hypoglycemia. We have the insulin being produced more prominently than the glucagon being produced more prominently than the insulin. Okay, so I'll go to the next slide. This slide just shows us basically the structure of insulin. I won't waste so much time on this. Okay, but we know that you can see that insulin has two chains. Okay, so we have the alpha and the beta chain, the alpha chain, the beta chain. This is actually pre-proinsulin on my left, and the C-peptide is chopped off it in the final step to releasing the insulin. And on the right is a graphical structure, the crystallographical structure of insulin. We'll just go further. We'll just mention that, of course, we all know that the work of insulin is to allow for nutrients metabolism, especially glucose, okay? We know that insulin binds to insulin receptor and leads to a chain of events through two pathways, okay? But the pathway that has to do with glucose metabolism directly is through this IRS pathway, that's the insulin receptor substrate pathway, that eventually leads to translocation of this GLUT4 glucose transporter. GLUT is simply glucose transporter. Leads to translocation of this to the cell membrane that allows glucose to enter the cell. In the absence of insulin, either lack of insulin itself or ineffectiveness of insulin action, which is due to some form of insulin resistance, this glucose transporter will not go to the cell membrane, and glucose will be locked outside. And so you have hyperglycemia, whereas the cells are starving, which we call starvation in the midst of plenty. Okay, so like I mentioned just now, that the issues in diabetes is either inadequate insulin production or insulin resistance, usually a degree of combination of this. We also do know that insulin resistance itself is not enough to cause diabetes, because usually the human body is able to produce insulin even in a higher amount to overcome that resistance. Simply put, insulin resistance is a condition in which you need higher amount of insulin to achieve the same glucose lowering, Of course, a lot of components underlying insulin resistance, which I will not go to because of time. Okay, but we need to understand it a bit, especially regarding treatment of hyperglycemia and when we need to use insulin for a person. Basically, free fatty acid and diacylglycerol contribute to insulin resistance, but oxidative stress, inflammatory cytokines causes some insulin resistance, and that's part of the reason why if the patient is acutely ill, if there's a lot of inflammation going on, there is this counter-regulatory hormone, the glucose, and you have hyperglycemia. Okay, so all these things, both the insulin resistance and the counter-regulatory hormones, all oppose insulin action, and we contribute to hyperglycemia and can make someone need more insulin than he will have needed, or can make someone that was previously well controlled on oral agents to start to require insulin either on a short-term or a long-term basis. In talking about the types of diabetes mellitus, we are all aware of this: type 1 diabetes, type 2 diabetes, other specific types of diabetes, which is a very broad class, and gestational diabetes. We know that type 1 diabetes is insulin dependent and they need insulin to survive. The insulin deficiency that happens in type 1 diabetes is almost absolute, okay? In practical terms, it's absolute, at least after the first 1 to 3 years, okay? And so for type 1 diabetes, they have to be on insulin, but the truth is that many patients with type 2 diabetes will also require insulin, which I'll go to along the line. Gestational diabetes is also usually insulin treated, even though there's been use of more and more, there's been increase in the use of oral medications for gestational diabetes in recent times. Okay, so I'll talk a bit about insulin use in Nigeria. And the initial scenario I'll look at is the studies reported by Olamoyegun et al. In Oyo State. I think that was done in Lautech, which shows that 90% of insulin users are actually patients with type 2 DM. And I believe that we all treat patients with type 2 diabetes. Also, the mean duration of diabetes before starting to use insulin, that's on average, is about 7 years, plus or minus 7 years. That's a lot of them will be between 1 and perhaps 15 years. So this reminds us that it's not only when you're treating patients with type 1 diabetes that you should be familiar with how to use insulin. And looking at the pattern of insulin use in Southeast Nigeria, in a study done in Southeast Nigeria, most of the patients were on twice daily, were using their insulin twice a day. And rather sadly, almost all of them were using needle and syringe to administer. And the use of pen device for insulin delivery was not common in that setting. Again, about 50% of patients still required healthcare workers to administer insulin, which is not good at all as well, because we usually like patients that are on insulin to be self-dependent and being able to self-administer the insulin, because if they require healthcare workers to administer the insulin, it will mean that at the time when the healthcare worker is not available or they're not able to pay that healthcare worker, they will not use their insulin and they will leave their glucose poorly controlled. Also, the last point from the study by Ignatius et al. In Humaya showed that only half of people who are using insulin self-monitor blood glucose, which is also poor too. So I think this actually highlights that there's a lot of gap in insulin therapy in Nigeria. Okay, I'll look at some more global trends now, which shows how much people are using insulin globally. This is over 200 million people that are using insulin globally, which is a lot of people. Among patients with type 2 diabetes, from studies all over the world, on average, between 20 and 30% of patients with type 2 diabetes are on insulin. And one of the major determinants, especially among people with type 2 diabetes, is the duration of diabetes. The longer the duration of diabetes, the more likely there will be need for insulin. And we know that diabetes is a progressive disorder. the incompetence of the body in handling glucose and other nutrients that happens in diabetes is not a static thing. It actually tends to go worse over the years. And because of that, the amount of intervention or the level of treatment that a patient will require in the first few years of diabetes the person will actually likely need more by 7 to 10 years of diabetes and more after. Okay. It's also from studies in the USA, ethnic minorities were less likely to receive insulin, and that shows gaps in care for people like that. Okay. There are many ways to introduce insulin among patients with diabetes. Some people start basal first, whereas some other people go directly to premixed insulin, but we'll go into that later. So briefly, I want to classify insulins now. We can classify insulin based on their biological source. We know that the earliest insulins were from animals, either from pork or from cow, that's from cattle. Those are the initial insulins, which are not commonly used now because of their immunogenic properties and the common allergies to them. Okay, but those are still available in certain settings. Okay, human recombinant insulin, which is the perhaps the most common type of insulin we have in Nigeria today, like the immunin hen, atrapid, and all the other ones are human recombinant insulin. And of course, we also have the analogs, which are the modified form of insulins. They're not just human recombinant because they're not identical to human insulins. Okay, but they have some amino acid modification, which makes them just look alike of insulin. We can also classify insulin based on the duration of action. We have the rapid-acting insulin and the short-acting insulin that start to act very fast, and they are often used either in hypoglycemic emergencies. They can also be used as before meal insulins. Then we have the intermediate-acting insulin, which acts for several hours, okay, but usually not up to 24 hours. And we have the long-acting insulin that can act for 24 hours. The long-acting insulin are also known as the basal insulins because they provide a background coverage, which we'll go into later along the line. Insulins can also be classified as either plain insulins or insulin that have been mixed already, okay? And the mixed insulin usually are a combination of either short-acting insulin and intermediate-acting insulin, or rapid-acting insulin and long-acting insulin. So we have the the rapid-acting component that will act for before the meal, and the long-acting component that will give like a basal component to it. And all the premixed insulin have a ratio that is written for them. So for example, 70-30 means 70% long-acting, 30% short-acting, and it goes for all the other components as well. Okay, so this is an interesting picture. On the right here, we have this syringe. Interestingly, this is how the hairless insulin syringe look like. They are made of glass with metal at both ends. They are incredibly clunky and they're very difficult and painful to use. Okay, we'll look at more insulin injection devices later, and we'll see how far insulin has come. The picture on the left is a fish. Okay, it's not just an ordinary fish; it's a river trout. Okay, and it's from this species of fish that protamine was actually used to be extracted from the sperm. So from the sperm of this fish, they extracted protamine, which was the first agent that was successfully used to protract the action of insulin. Okay, so our NPH insulin, which is an intermediate acting insulin, is actually a protaminated insulin, and protamine is actually still used to prolong the action of insulin. We'll talk about how that is done, and so that's still relevant today. So we'll go into insulin. We'll talk about insulin absorption a bit now before we talk about the types of insulin and how to use insulin. So first of all, many doctors don't know this actually, but insulin, when given intravenously, it has a very short half-life. The half-life when given in IV is around 5 minutes, okay? And the effect disappears usually within 30 minutes of injection. And that's why IV bolus insulin is not a it's not really a viable, it's not a sustainable way of administering insulin because the effects wears out very fast actually. If we need to use insulin IV, then it has to be a continuous infusion so that the effects can be sustained. Okay, but more often insulin is administered in a subcutaneous manner, and subcutaneous insulin is used for soluble insulin. When administered, it forms eczemas. I think I'll go into this along the way, so I think I'll just keep the remaining. But IV intravenous insulin has a very short half-life, and if insulin needs to be used intravenously, then it's better given as a continuous infusion. Okay, so this is a very busy slide. I know you have to forgive me for that. Okay, but I need to capture. I needed to capture most of the available types of insulin on this slide. So, but I'll just go into that. I'll just go into them a bit. I'm trying to look for a zoom area. Okay, so anyway, so yeah, we have the rapid-acting insulins. The rapid-acting insulins, there are three that are generally in the market. I'll go into all of them along the line. Okay, but we have the rapid-acting insulins, aspart, lispro, and glilocin. All the rapid-acting insulins are analogs. Okay, and of course, they are more expensive than the regular or soluble insulin. Okay, all of them are analog. All the rapid-acting insulin are analogs, and all of them come, at least in Nigeria, all of them come in either a cartridge to be used in a pen device, or comes as a pre-filled pen device. So there are no regular 10 ml vials of rapid-acting insulin, no. Okay. Then of course we have the short-acting insulin, which is a soluble insulin, or Humulin R, or the Actrapid that we are all familiar with. Okay, so we have those. We also have the intermediate acting insulin, which is basically MPH insulin. The MPH insulin is either Humulin N or Insulatard, depending on the company that is producing it. Then we have the long-acting analogs. We know that the intermediate acting insulin, they act for an intermediate period. It doesn't usually get up to 24 hours, maybe usually up to 18 hours, okay? And that's why it is not really classified as a long-acting insulin, okay? But the true long-acting insulin are the basal insulins, and they act for usually up to 24 hours. Insulin, those are the insulin detamere, insulin glargine, and insulin degludec. The degludec actually acts for up to 24 hours. I will also go into these subtypes of insulin bit by bit along the line. We also have the mixed insulin, which are the premixed insulin that I've talked a bit about. Some of them are mixed human insulins. Some of them are mixed analog insulins. The analog insulins, like I mentioned earlier, are the insulins that they're like human insulin, but some amino acid substitutions have been made so as to alter the property of this insulin, and we'll go into that along the line. All of this affects the profile of the insulin, and I would also talk about the rationale for choosing which over the other among the insulins. Okay, so first of all, I'll start with soluble insulin. Soluble insulin is the one that we are all mostly familiar with. Soluble insulin is unmodified human insulin, and even though it's developed by DNA recombinant technology, if you actually combine the soluble insulin in the vial to what you extract from a human being, they will actually be biochemically the same, okay? It's transparent and it can be mixed in IV fluids, and that's why it's called soluble. It can be injected, can be administered by the IV route or by the subcutaneous route. But of course, the caveat, which I said, the caveat I gave about the IV routes before still stands, that it has a very short half-life when given IV, okay? But because it's soluble, it can still be given IV, okay? The subcutaneous form, when given in the subcutaneous form, it forms eczemas, which are like microprecipitates, and this progressively dissociates into absorbable forms, okay? Now, because it forms these eczemas, which is not really a desirable thing, but there's no way to go about it, it has a long lag time before it starts to act. And the onset of action is between 30 and 60 minutes, which is very, very inconvenient. Actually, that 30 to 60 minutes lag or onset of action can even be longer in some people. And you can imagine taking insulin injection before food, and you have to wait for up to an hour before you eat the food. And the doctor has also insisted that the food must be available before you give the injection, so that there is little or no risk of the person slipping into hypoglycemia. Okay, so that's an inconvenience with the soluble insulin, and of course that leads us later to the story of why the insulin analogs were developed. The duration of action of soluble insulin is 6 to 8 hours. It will look like a good thing that it has for a long time, okay, but sometimes it can be a serious inconvenience. So imagine I had my breakfast at 8 a.m. I took my sub-Q soluble insulin at 7:30. That's 30 minutes before then. If I ate at 8 a.m., it means that if it's active for up to 8 hours, it will act up to 4 p.m. But this is an insulin that you want to use before food. Assuming I'm eating 3 times a day, I'm going to eat my lunch at 2, and I want to use another insulin at that time. You can imagine what's going to be happening. That means there will be an overlap in the action of the insulin I use in the morning and the one I'll use at lunchtime. And that overlap is not a useful overlap because the insulin is at the tail end of action. That is, the action is waning at that time. And because it's waning, it cannot cover for a meal. You actually still have to give another insulin. And that leads to some build up and overlap in the action, which is good for, it's beneficial in terms of giving a basal coverage, so that even if the person was not using a 24-hour background insulin, there's some background coverage at that time, okay, but it distorts the monitoring with food. So that's one. And of course, it can lead to relatively low sugar than one would have expected after lunchtime. So, but it's suitable for before meal use. Like I mentioned earlier, the 30-minute wait that is necessary is a big inconvenience for people. Imagine that we went to a restaurant and we wanted to eat with my friends, and then I quickly went to the bathroom to jab my insulin. Then I now have to wait for 30 minutes before the food. And the doctor has told me that I should not take the insulin before leaving my house because there can be delays in the restaurant, the food may not be ready, and I may end up walking, which will make the insulin act more intensely. So the person has to wait now before he hits his food. It's a bit awkward sometimes. Okay, so and those are the reasons why the rapid acting insulins were developed. The rapid acting insulins, like I mentioned, are amino acid modification of the human insulin, and there's less eczema formation with more rapid release into the bloodstream, leading to a faster onset of action and a briefer period of action. So the duration of action is usually less than 6 hours, between 4 to 6 hours. Also, the peak concentration is higher if you're using the same dose compared to the same dose of soluble insulin. And because of this, when we are converting someone from soluble insulin to a rapid-acting insulin, usually you have to reduce the dose to a certain extent. Of course, because of the more rapid onset of action, it can be injected 5 to 10 minutes before meals. We actually tell some people they can inject it immediately before meals if they don't want to wait for 5 minutes. The consequences are very minor. Okay, the risk of hypoglycemia is also less because it doesn't act for too long a time. Okay, and it can be used in insulin infusion pumps, which I'll talk about later along the line. Okay, so this chart shows the rapid-acting insulin. The 3 rapid-acting insulins are in the market. The first one is Lispro, which the version produced by Lilly is called Humalog. Okay, this Lispro is made by reversal in the beta chain lysine for proline. So that's where the name actually comes from, Lispro, lysine proline. Of course, the insulin analogs are less immunogenic, okay? But in addition, because they act very fast and for a briefer period of time, in people in which feeding is less predictable, it can be given immediately after food instead of before food, even though ideally the rapid-acting insulins, like the soluble insulins, ideally should be before food, okay? So we also have insulin aspart as a rapid-acting insulin, and the common brand in Nigeria is Novorapid, developed by Novo Nordisk. So that's insulin aspart. The properties are about the same, basically. There's actually very little difference between them, okay? Then we also have the insulin glycine, that's Apidra, which is less available, but it's actually still available in Abuja as well. Okay, so I'll talk about the NPH insulin now. The NPH insulin, neutral protamine adagon, was one of the very early longer acting insulin, which is actually intermediate acting insulin. Okay, I mentioned about the protamine earlier, which makes the insulin stay longer in the subcutaneous tissue and is gradually dissipated into the system. The onset of action is about 2 hours, okay, but it's a fairly erratic insulin. You can see that the peak can be anywhere between 6 and 14 hours, which is a lot. The range is just too wide, between 6 and 14 hours peak, and then the duration of action is actually also not very predictable, between 10 and 16 hours, but could be longer, can be up to 18 hours, okay? There's also a phenomenon that we call Somogy effects, in which, because it peaks, is an intermediate acting insulin, and but many times it's used like a basal insulin, or it's used as a background insulin, and it's often administered at night, okay? But because it peaks, in some people it can peak around between 12 midnight and 2 a.m., leading to hypoglycemia. And in those kind of circumstances, some people can have the Somogy effect, in which they have a rebound hyperglycemia in the morning, which can be erroneously thought to be due to inadequate dosing of insulin. That's the Somogy effect, okay? But the good thing about the MPH insulin is that it can be mixed with soluble insulin. It can be mixed with soluble insulin, either pre-mixed or self-mixed by the patient. Okay, so of course, we also have the basal insulins, which are the long-acting insulins, and they act for at least 24 hours, some more, okay? They provide a background insulin coverage for the patients. I would explain the background coverage and the prandial coverage later. That's the prandial coverage, that's the mealtime coverage along the line, and the way it mimics natural human physiology. I'll talk about that along the line. But the function of basal or background insulin is actually to suppress hepatic gluconeogenesis. It's always amazing to people with diabetes when their sugar is still high, despite that they've not eaten, or they've just been eating vegetables or some very low carbohydrate stuff. The truth is that, of course, the body can produce glucose from other means in the body, even from the muscles and from the fat stores, etc. in the body, okay? So there is part of the consequences of insulin deficiency or insulin resistance is uncurtailed hepatic gluconeogenesis, okay? But diabetes treatments, even oral agents like metformin and co, but also insulin can suppress hepatic gluconeogenesis, and that prevents glucose levels from rising, especially in the fasting state, in people who are functionally insulin deficient, okay? The basal or long-acting insulin also prevents ketogenesis in patients with type 1 diabetes when they're not eating. And usually basal insulin can be continued even if the person is not eating, because it's just a background insulin, and we all produce insulin even when we're not eating. Okay, so one of the basal insulin, one of the most commonly used basal insulin in Nigeria is insulin glargine. All the basal insulins, they have different modifications, okay? The insulin glargine is formulated at an acidic pH of 4.0, and many patients will tell you that it stings them when they inject it, okay? But when it gets to the subcutaneous tissue, it's neutralized and it forms microprecipitates, which is now gradually released at almost a constant rate throughout the 24-hour period, and it's peakless, okay? So that's insulin glargine. Is a true basal insulin. It doesn't really have a peak, and when used at about the same time every day, a virtually constant level is maintained. Of course, it cannot be mixed with any other insulin, because the pH is actually quite acidic the way it is in the vial. But if you mix with another insulin, it distorts this pH and is likely going to precipitate if that pH is neutralized. The onset of action is about 2 hours, okay? So the onset of action is about 2 hours, and it acts for between 20 and 24 hours. Some sources will quote a longer period, and it's typically given once a day at any time of the day, but the timing should be consistent. If someone requires more than 50 units a day, then the doses should be divided into twice daily dosing. It's often used instead of MPH insulin, and compared with MPH insulin, it is more predictable, and then the risk for hypoglycemia is less, obviously, because it is a peakless insulin, it's a relatively flat insulin. MPH insulin is particularly when the glucose control is getting to target or very near targets, which we call tight glucose control. At the peak, the sugar might dip a bit in people using MPH insulin. One of the other available basal insulin is insulin determer, that's Levemir. Also come as a pre-filled pen like Glargine in Nigeria. Okay, the modifications is different, and the mechanism for the delayed absorption, for the slow and steady absorption is also different. Okay, that for determer is actually because it binds to albumin in both the subcutaneous tissue and in the bloodstream, which gives a slow and steady distribution to the peripheral tissues. The onset of action is the same as Glargine, but the duration of action is probably somewhat shorter, okay? And most people administer it once daily, okay? But for some people, especially in people in which the duration of action has been proven to be shorter, and in those people, before the next dose, you see that the sugar level, the glucose level starts going up. In such people, they should be on a twice daily dosing regimen for the determer. So compared to the Glargine, comparing the determer to the Glargine actually has a more consistently longer duration of action compared to the determer, which is a good property for a basal insulin. The last basal or long-acting insulin on the list is insulin degludec, which is a very long-acting insulin. So it's an ultra-long-acting insulin. It forms multi-hexamers. I mentioned earlier that soluble insulin forms hexamers in the body, in the subcutaneous tissue after injection. So degludec actually forms a lot of this, which leads to a very slow and steady release of insulin. And this can happen for over 42 hours, okay? So it's actually very efficacious, and the occurrence of hypoglycemia in people on degludec is actually probably slightly less compared to people on the other basal insulin, okay? The other good thing, if you may, about degludec is because of the very long duration of action, even though it should be used every day, it's not necessary to use at the same time of the day. And then if someone misses a dose on one day or the other, the consequences or the implications is much less. Also, because the degludec is one of the last ones of these basal insulins to be produced, they have cardiovascular safety data as well. Okay, so I'll go to the premixed insulins, which many of us are familiar with. I think the most commonly known premixed insulin in Nigeria is Mixtard or Insulin 7030, okay, which is a MPH soluble insulin mixture. Is well used, and patients and people are well familiar with it, which is good. Okay, so that's one of the most common premixed insulin. But we also have some premixed insulin analogs, which includes the first one. The first one is the aspartate and protaminated aspartate, which is Novomix. Many of us know it as Novomix 30. And then the second one, I should have written it in brackets, is Humalog mix. That's Lispro and protaminated Lispro. Now, I've mentioned earlier that protamination prolongs the absorption and release of the insulin from the subcutaneous tissue. So it makes it at least act intermediately, so act for a longer extent, okay? So this is a short-acting component with an intermediate acting component. I will consider the longer acting component is the larger component. So it's the 70, 75, and the 50. So these premixed insulin are also known as biphasic insulin, and that's because they have two peaks. There's a peak from the short-acting component, and then there's a peak of the intermediate acting component. The peak of the short-acting component is usually higher than the peak of the intermediate acting component, okay? The beauty of premixed insulin in people that need it is that of the convenience of twice daily dosing, rather than whatever we're comparing it to. In this case, I'm comparing it to a 4-time daily dosing injection of a basal bolus regimen. Of course, the main limitation with a premixed insulin is the fixed proportion. So in practice, someone can actually, instead of 70-30, someone may actually functionally need 20-80 or may need 60-40, which may not be available. So we just have to work with the proportion that is available, and the person will now have to modify this meal types, meal sizes, and lifestyle towards that insulin, rather than having the insulin being modified for the person. Of course, to overcome this barrier, sometimes we do self-mixed insulin, which the person actually withdraws a certain amount of each of these components himself. Okay, but that's less commonly done these days. And of course, for for the premixed, twice daily premixed insulin, usually a person often has to eat lunch, especially for these MPH soluble mixtures like Mixtard and Insulin 7030. And that's because the second peak, the peak of the longer acting component, that's of the MPH component, can be quite significant, so that if the person does not take lunch at lunchtime, usually around 4 to 6 hours after the breakfast, the person can experience some hypoglycemic symptoms if the person does not eat at that time. So that flexibility is lost while using a premixed insulin component. So for premixed insulin, usually in starting, let's say we want to start someone on, on Mixtard or Insulin 7030. This dosing is actually referring to premixed human insulin like Mixtard or Insulin 7030. So the typical starting dose is between 0.5 to 1 unit per kg per day. Usually you should err on the smaller side if you are trying to be cautious, one. But of course, if the severity of the hyperglycemia is marked and this glucose is quite elevated, you may go towards the middle, but maximum of 1. But I won't recommend using 1, particularly for a non-specialist. So let's say someone weighs 80 kilograms and I want to put the person on 0.5 units per kg per day. So 0.5 times 80 is around 40 units. Then I'll take that 40 units, I'll calculate that as the total daily dose. And I'll give 2/3 of that in the morning, 1/3 in the evening. So 2/3 of that will be something more than maybe around 26 or so. And then the remaining will be before dinner. So that's how to dose it. Sometimes if you are wary of monitoring, you can actually scale even lower than this 0.5. But the standard starting dose for someone that is quite insulin deficient should be between 0.5 to 1 units per kg per day. And the dosing is like that. So the people that usually benefit from starting on premixed insulin are people with type 1 diabetes. Even though basal bolus regime, which we'll talk about later, is more appropriate for people with type 1 diabetes, sometimes it's not acceptable to them, and sometimes it's not practical for the patient. So sometimes we have to come to a compromise of using a twice daily premixed insulin for them. I'll talk about the insulin regimens later. Also, for patients with type 2 diabetes mellitus, they can be started on twice daily premixed insulin, or sometimes once daily, when oral agent is not achieving control, or when there's a marked rise in postprandial blood glucose for the patients. Okay, there are also some insulin formulations in which there is a combination of insulin and glucagon-like peptide-1 analogs. They are pre-combined together. Of course, the GLP-1 analogs are expensive, so these combinations are quite pricey. Okay, but none of them has had approval in Nigeria, to my knowledge. Okay, but they are available at some exclusive pharmacies. But I'm sure we might see some patients that are using this from outside the country. So, of course, the benefit of this is that your person will require a less dose of insulin. That's one, and of course, usually there will be less weight gain, which can be associated with insulin, because these GLP-1 analogs are more likely to cause at least some extent of weight loss. Okay, of course, the world has also experimented with inhaled insulin, and that's no surprise because insulin having to be injected is a stress for most people, both for patients and for healthcare providers. So many other things has been explored. And inhaled insulin is actually available, okay, but it has not been quite successful for some reason, okay? So inhaled insulin is delivered as technosphere, the powder like technospheres, and it's inhaled with a device that is almost like an inhaler, or not quite an inhaler, and it's absorbed in the lungs, that's in the lower respiratory system. And not surprisingly, it actually peaks quite faster than even the rapid-acting subcutaneous insulin, and is very effective in lowering the postprandial blood glucose compared to the rapid-acting subcutaneous insulin. Okay, but of course, it has potential side effects. It causes dry cough in a lot of people, and for most people, there's a reduction in the respiratory function parameters, particularly the FPV1. That's the first expiratory volume in the first second. Okay, fortunately, that respiratory parameter change is non-progressive and is reversible. Okay, but it makes quite a lot of people wary of using inhaled insulin. Of course, there's been a quest for oral insulin formations, okay, but there's been many challenges in making oral insulin formations, and until these challenges are overcome, it will still be a challenge to have oral insulin. But some of the researches has been more promising than they were before, but there's still a lot of ground to be covered, and this shows many of the delivery challenges. Number one, insulin is a peptide and can easily be broken down by the substances in the intestine, both the acid in the stomach, the enzymes in the intestine, bile can break down insulin quite very rapidly. Now, there are some things that have been done to try to overcome that. But again, insulin is a large molecule. It's larger than, the size is over 5,000 kilodaltons or so, okay? Which is too big to cross the tight junction at the intestinal borders, okay? So that's two. And then thirdly is the bacterium and other bacterial flora in the intestine. So all these things are challenges for administering insulin orally. And for the foreseeable future, insulin will likely either be will be administered parenterally, either subcutaneous, IV, or recently available inhaled. Okay, but the researches are still promising, and there is one that was discussed recently. I'm not sure of the name of the company that is working with that again, in which there's actually like a small capsule that has a sharp end that is made of insulin. So literally, the capsule injects, it lands in the stomach and injects itself in the stomach mucosa, and then the needling points, which is made of insulin itself, will get absorbed as well into the body. Okay, but those are just research points, okay, and will be areas of interest in the near future. Okay, so we go to insulin regimens now. Okay, so this picture shows the physiological insulin secretion profile. Okay, and we can see that, I believe we all know this actually, there's a basal insulin production, so the insulin level never goes to zero. There's no zero there. Okay, there's a basal insulin production, that's the minimal amount that is there all the time to counter gluconeogenesis, to counter ketogenesis, to counter lipolysis. That's just there. It's only during significant hypoglycemic episode that background insulin level is almost missing. Okay, but anytime we eat either breakfast, lunch, dinner, or a snack, there's a surge in insulin levels just to help us mop up the nutrients that is delivered by that nutrition. Okay, and this is actually what we try to cover when we're treating someone with diabetes for glycemic control. Okay, so I'll give you a case scenario now, and we'll just look at it together. So here is a 41-year-old man that was admitted with acute abdominal pain and distension. A diagnosis of ruptured appendix with peritonitis was made. A urgent RBG was done, which was very high at 400 milligrams per DL. The full blood count showed neutrophilic leukocytosis, which is expected. Urinalysis and EUCR were normal, which exclude the diabetes ketoacidosis state, which can be a differential. It is not a known diabetes. Please forgive my typographical error there. Okay, so the surgical team planned an immediate X-lab and invited you, the medical team, for glycemic control. So how should this hyperglycemia be managed? How should this hyperglycemia be managed? Of course, I'm going to give us, but we should think about it. I'm sure we all have different things in our head now. You'll do this, you'll do that, this is how this should be managed. Because, of course, obviously, while the surgery is an emergency surgery and should be done as soon as possible, the hyperglycemia cannot be ignored either. It should be controlled while the patient is being prepared for surgery, during surgery, and after surgery. Okay? So I'll talk a bit about insulin regimens now, and after that, we'll probably reflect again on how we think this should be managed. Okay? So the first insulin regimen I'll talk about is the basal bolus regimen. Okay? And basically, the basal bolus regimen is very simple. It's stressful, but it's very simple. And it basically tries to mimic this physiological insulin secretion that we've talked about earlier. Okay, so it tries to provide a kind of background coverage on this line I'm drawing, and try to provide some surges for meal. So it should just be for the meal, and she'll keep quiet after the meal. That's what we want, okay? So it gives this background insulin and multiple prandial doses of the short or rapid acting insulin. So usually there's multiple daily injections, usually 3 or more, many times 4, but people that don't take lunch, they can be fine with 3. It is very intensive. It is very stressful for both the patient and for the healthcare provider, and requires a lot of motivation, okay? It's most ideal for people with type 1 diabetes. That's the best regimen for some, or not the, that's one of the usual regimen for someone with type 1 diabetes. And it's also ideal for inpatient settings, okay? But definitely, the more injections we're giving, the more monitoring we need. So it requires more monitoring, and the monitoring, both the injection and the monitoring can be quite stressful. And a typical type 1 patient that is on basal bolus insulin regimen, you will be able to see the finger prick marks at the tip of the finger, because the person oftentimes will check up to 4 times a day, okay? It gives great flexibility, however, and flexibility in terms of timing of meal. It doesn't force you to eat at a particular time. Even there's more flexibility in what the person will eat, because the prandial insulin, that's the mealtime insulin, can actually be quite adjusted to the amount of calorie the person is about to take. So that's the beauty of the basal bolus regimen. Okay, also we also have the premixed insulin regimen that I've talked about to some extent earlier. I mentioned earlier that the risk of lunchtime hypoglycemia is there if the person does not eat at lunchtime. So let's say I'm using a twice daily premixed insulin, and the doctor has put me on either mixed start 20 units in the morning, 10 units before dinner, and I took my mixed start before breakfast at 8 o'clock. For most people with either type 1 or type 2 diabetes, by the time it's getting to 1 or 2 p.m., if they don't take their lunch, they will start to have hypo symptoms, especially if they were physically active at their workplace or in school, working at that time, okay? So the lunch is actually compulsory at that time, otherwise you can have hypo symptoms. And it's not like that for basal bolus regimen, because if you use short-acting insulin in the morning in a basal bolus regimen, by 2, at least there's no spike, even though there's still some insulin that is still gradually reducing, but there's not going to be any peak around that time, which is what we have with premixed insulin, okay? So I mentioned earlier that premixed insulin is used both in type 1 and type 2 diabetes, but it's less ideal for type 1. In people with type 2 diabetes that are being converted to premixed insulin, the oral agents are typically stopped, okay? But metformin may be continued, okay? But other oral agents, especially the ones that can increase insulin secretion, such as sulfonylureas or the DPP4 inhibitors, are typically discontinued when a patient with type 2 diabetes is being started on a premixed insulin, okay? I mentioned the compromise earlier. It's not physiological, and of course, there's less flexibility in terms of the timing, the meals, and then adjustments. I mentioned the compromise in the adjustments earlier. Sometimes someone is using premixed insulin, and it's actually the mealtime one alone you need to adjust. The basal is fine, okay? But because the insulin is pre-combined in a fixed proportion, you can't adjust one without adjusting the other. So that's part of the limitations that we have with premixed insulin regimens. So this is one of the regimens that I want to encourage people to start using more and more, and that's basal insulin as an add-on to oral agents. Obviously, it's typically in type 2 patients with type 2 diabetes that are not meeting their glycemic targets. Okay, and here we're talking about patients that are on near maximum tolerated doses of oral glucose lowering agents, and they're still getting A1C that's above target. So in such patients, we need to escalate their treatment, and there are many ways to escalate these treatments. Approaches vary, like I showed previously in the broad use of insulin in Nigeria and globally. One of the approaches to use is to add basal insulin to the oral agent as an add-on agent, okay? And that's been done more and more commonly now, especially since the true basal insulin, like the glargine and bitamine, are more available now, okay? So usually, once daily basal insulin is just simply added to the patient's regimen. And the typical starting dose is between 0.1 to 0.2 units per kg per day. So for example, if the person is weighing 100 kilogram, then you can start the person on between 10 and 20 units per kg per day of the basal insulin. You also let, apart from the weight, you also let the degree or the severity of hyperglycemia guide you as well. So if the hyperglycemia is quite marked, you lean more towards the 0.2. If it's quite mild, you lean more towards the 0.1. But the most important thing is to titrate. And that's what many people, both doctors and patients, fail to do, is to titrate. There's no point suffering and using insulin and now not using it at the optimal dose. The injection, the prick is still the prick. So if you're pricking, then we might as well prick and deliver the appropriate dose for the person. So it should be titrated every 3 to 5 days by increasing the insulin based on the fasting blood sugar glucose until the fasting blood glucose targets are met. Then we should maintain the effective dose. So we should remember to titrate. And of course, usually when someone is started with a basal insulin as an add-on to oral agents, there is often some modification to the oral medication depending on what the person was on before and the doses, okay? But oftentimes the sulfonylureas is stopped or the dose can be reduced. Sometimes we continue it, okay, but we should be careful to monitor the postprandial glucose if any insulin secretagogue is still being used with the basal insulin, okay? Because oftentimes, because doctors often delay starting the basal insulin until things are very bad and they've really maximized other oral agents. At the time they're starting, for example, the fasting blood glucose can be something in the range of about, let's say 160, and the postprandial can be, because they're using a lot of secretagogues as well, postprandial can be, let's say, around 180, which is not problematic. But by the time that fasting really drops, is brought to normal, the person can start to have postprandial hypoglycemia if the sulfonylureas are not either reduced or stopped, okay? So that has to be done carefully, okay? There's also a regime called a basal plus insulin, which, basal plus insulin regimen. I didn't describe it so much on this slide, but I'll talk about it, okay? So I mentioned earlier now that if we're starting someone on a basal insulin, so a patient with type 2 diabetes that is not getting to go on maximal tolerated doses of oral agents, one of the approaches is what I said just now, that we can add a basal insulin. But when the basal insulin alone is not working, then we have two options. Either we go to a twice daily premixed insulin, or we do what we call a basal plus. We don't do this basal plus often in Nigeria, and I'll tell you why after. But the basal plus regimen is just basically you continue that basal insulin, but the patient now look at the largest meal of the day and add a prandial insulin to it. The prandial insulin, that's a pre-meal insulin, will, in that case, will either be a rapid-acting insulin or soluble insulin. We just use it just before the largest meal of the day. And I'm sure we all know that most people take one large meal of the day, and then the other meals are quite relatively small, especially people in some parts of the world, like in Nigeria, actually, okay? But the challenge with this, the little challenge with this in Nigeria is that the person has to buy two different insulin. It's not like the cost will likely be more because it probably will not affect the total daily units being used, okay? But it will be seen as that, okay? So using this regimen is actually not terribly common in Nigeria, but it's a very valid and effective regimen. And you will know, what people notice is that once you get a prandial insulin that controls the surge of the largest meal of the day, usually after the other meals, there's no significant postprandial hyperglycemia. Okay, so this is a graph showing the things I've discussed now. So we have the first line. Let me get my highlighter here. So yeah, so the first line, the once daily basal insulin, depending on the agent you're using, most of the basal insulin are relatively peakless, so you just get a flat coverage throughout the day. It's unlikely, the insulin is unlikely to get to any level that can cause hypoglycemia, and usually we continue the oral agents with this. So that's the first graph. Okay, the second graph is that of a twice daily premixed insulin. Okay, so we have that here. There's a surge of the short-acting component, surge of the short-acting component. This graph is not really showing the smaller hump or smaller surge of the of the longer acting components. Okay, but basically it works like this for that. And on the last part, we have the basal bolus regimen, in which we are using two different types of insulin, and hence the two different colors on this graph. So we are using this basal insulin, the gray one, which gives a background coverage, and we use a bolus before each meal. The person is not going to eat, the person will not use the bolus. So that just looks at the very three common outpatient insulin regimen. Okay. So now I'll talk about some other insulin regimens which are more often used in patients. Okay. So we have the basal plus correctional insulin regimen. It's difficult to get a uniform name for this regimen. Different people call it slightly different things. Okay. But of course, I'm sure we've all heard, or perhaps are familiar with the traditional sliding scale insulin regimen, in which the blood sugar is checked, and based on the value that is gotten, a dose of soluble insulin or a regular insulin is given. So that's the traditional sliding scale regimen. If I'm talking about it in this era, instead of soluble insulin, a rapid acting insulin can be used, but that's sliding scale, okay, which has its own issues, which the basic issues is because it's reactive. The sugar will just be literally going up and down throughout the course of the patient's inpatient stay. And because of that, we now know that if you give a basal insulin and give a constant basal insulin, and you give the rapid insulin as correctional insulins, the glycemic control is usually much better. So the people in the settings in which it is appropriate is in inpatient settings, as patients that are on admission, that are on nil per hora, or the oral intake is uncertain. Okay, so it's not a meal-related regimen. So usually we give the patient a basal insulin, either glargine or detamine, at about 0.2 units per kg per day. We give that constantly. I've mentioned earlier that it's irrespective of meals, okay? And the glucose is checked at certain intervals. I'll show you the protocol. I'll show you briefly the protocol we use in cardiocare after this. The glucose is checked at certain intervals in such a patient. For many of them, the glucose will just basically be fine. Will be within the target range, okay? But if the glucose gets to certain levels, then a certain dose of either rapid acting or soluble insulin is administered based on the sliding scale. And the sliding scale that is used for that is just similar to the common sliding scale insulin regimes. I would just give me a moment to explore and show the protocol we use for that here. Just give me a second. Okay. Okay, just a moment now. Okay, so I'm here now. So where did this? Okay, I hope the screen is showing. Okay, so we can see this. Okay, so for the basal plus supplemental or basal plus correctional insulin regimen, we give a basal dose of insulin, usually between 0.1 and 0.2 units per kilograms of the basal insulin, which often lantus or detamine. Okay, that is fixed and given constantly, and then we give supplemental insulins based on the blood glucose check. Okay, so the patient got basal insulin at a certain time, and the blood sugar glucose is checked every 6 or 8 hours. So in this case, so based on what is obtained, the patients, a certain amount of soluble or rapid insulin is administered for the patients at that period of time. So basically, that is the basal or supplemental insulin, and it's most suitable for people that are either on nil per hora or have uncertain oral intake. Okay. We also have intravenous insulin infusion, which is usually used in high dependency units and ICU settings. Okay, So for example, for our own patients that come with hyperglycemic emergencies like diabetic ketoacidosis and HHS, we use intravenous insulin infusion for them. And it's also useful perioperatively if you need a very fine control of the blood glucose of the patient, which definitely is needed for diabetic patients going for surgery, like the patient in the scenario I mentioned earlier. So I've given us expo for that. Okay, so intravenous insulin infusion is given using a syringe pump, and the insulin is usually diluted in normal saline. Usually a 50 ml syringe is used with the infusion pump, and then the flow is titrated to keep the blood glucose within target range. Okay, so the flow rate is continuously increased until the blood glucose is within target range, and then that flow rate is maintained. Okay, is actually the most perhaps the most effective way of controlling glycemia for critically ill patients. When our patients with diabetic ketoacidosis comes like that, we rehydrate them on one line and start insulin infusion on the other hand. And usually with that, you can get beautiful outcomes in addition to other things that should be done for the patient. Okay. Of course, when the blood glucose is up to a certain extent in patients with hyperglycemic emergency, any patient actually, you have to start glucose and electrolyte infusion through another drip or through a Y-shaped cannula on the same drip. Because if you're giving insulin infusion alone with a blood glucose of less than 200 milligrams per DL, you will likely it's possible for you to go into hypoglycemia within a short time. Okay, so the target blood glucose depends on the clinical condition, but oftentimes the target is between 140 and 180 milligrams per DL. In some conditions, you can aim as low as 110, but usually we should not aim less than 110 because studies have shown this to cause more harm than good. Okay, so we also have the GKI infusion regimen. That's the glucose potassium insulin infusion, which many of us are familiar with. GKI infusion can substitute with IV insulin infusion where facilities for IV insulin infusion is not available. For IV insulin infusion that I mentioned earlier, obviously it requires a syringe pump, it requires an ICU setting, it requires trained nurses, it requires existing protocol, basically requires things like that, and of course very frequent checks of the blood glucose. Okay, but aside from that, the settings in which GKI infusion is relevant is also the same setting in which the insulin infusion is relevant. So you can put it as a low cost, you can consider it like a low cost insulin infusion regimen, even though of course it's not as effective. Okay, so in hyperglycemic emergencies, in critically ill patients, in patients on nil per hour, you still need to keep their glycemia under control. Don't forget that in patients on MPO, I mentioned that the basal plus correctional insulin is also an option, but this is also an option for them. It can also be used perioperatively. Okay, and usually we constitute the GKI by mixing dextrose infusion, either dextrose saline or dextrose water, with soluble insulin with potassium chloride. Okay, the ratio is variable. Okay, so it can be 555, 5510, 510, depending on the blood glucose level and depending on the potassium concentration. And the ratio is adjusted based on the blood glucose trend using a written and standardized protocol. I think I will still try to share part of the protocol we use in cardiocare for this. Okay, so even when a GKI infusion is being used, it's often used as just a drip. Okay, but if an infusion pump is used, increase the accuracy of delivery, or a SoloSet device is used, if it's used, increase the accuracy of delivery, because you don't want to be giving someone a glucose potassium insulin infusion and then the patient does his hand like this and the insulin glucose infusion flows very fast, or the patient does like that and it flows very slow. That will give a lot of erratic values in the blood glucose control, which is not good. Irrespective of the infusion being used, whether it's a syringe pump for the IV insulin infusion or a GKI infusion, monitoring is very key. Okay, and usually it's done. I'll talk about monitoring along the line anyway. Okay, so this case scenario I gave earlier, the patient with severe hyperglycemia being planned for emergency XLAP. How do we think the hyperglycemia should be managed? I would like people to comment in the chat box. Do you think the person should be given soluble insulin. I mentioned that the random blood glucose is 400. That's in excess of, how do we convert this again? So that's in excess of around 20 millimoles per liter if you're more used to that. Okay. Should we give the patient, should we start the patient on sub-Q soluble insulin intermittently? Should we start on basal bolus insulin? Should we just focus on normal saline hyperinfusion? Okay. Or should we start intravenous insulin infusion using a syringe pump? Or should we go for a GKI infusion? Any ideas in the chat box, please? I'll give us a moment to look at this. So again, where am I? So again, the patient is a young man, I think I said 40 years old, who was brought in with a surgical abdomen, okay, and they were planning for emergency XLAP, but the person was found to have severe hyperglycemia, random blood glucose of 400 milligrams per DL, okay. Option E, oh yeah, so I get a lot of people suggesting for option E, which I think I agree with, even though intravenous insulin infusion using a syringe pump will actually be the best option here for the control, okay? But in many settings, in many of our settings, especially if the device, the training, and other facilities for using intravenous insulin through a syringe pump cannot be done safely, then you should go for a GKI infusion, okay? But if you actually have all the facilities, for example, if you're in John Hopkins Hospital or cardiocare, you can actually use intravenous insulin infusion using a syringe pump, okay? But in the absence of that, then GKI will be the next best option, okay? But the first 1 to 3 options would not be appropriate, okay? You can't use sub-Q soluble insulin only in a patient that is critically ill. Number one, the time for absorption is going to be very slow. You need to get this patient for surgery, and you cannot fine-tune the the action of sub-Q soluble insulin. You have for 8 hours. Once it's there, it's there. Okay. Unlike intravenous insulin, that if the glucose is going low, you can quickly reduce it. If it's going high, you can quickly increase it. So you don't have that control or any sub-Q form of insulin will not be appropriate for this patient. The person needs a intravenous insulin, which can either be done with a syringe pump or as a GKI infusion. Okay. So this is an infusion pump, not a syringe pump. Okay. So many times when we're using a syringe, when we're using even when we're using GKI, it's good to use an infusion pump. This can actually really regulate the flow of any fluid that is being put up. Also, any fluid that contains medications like insulin in terms of GKI now or any other medication, the rate should actually be controlled so that you get a specific drop per minute. Okay. On the right side of this is a continuous subcutaneous insulin infusion pump. Sadly, many of the names sound alike, okay, but a CSI device, that's a continuous insulin infusion pump, is actually a outpatient insulin delivery device, okay? So it's for patients with either type 1 diabetes or diabetes in pregnancy. I'll talk about it along the line later, but even though basically they do about the same thing compared to a pump, okay, but this is an outpatient device and it's a wearable device. Okay, so here I talk about the continuous subcutaneous insulin infusion. Okay, so that's a continuous infusion of always a rapid-acting insulin into the subcutaneous tissue. Okay, and it's done using a specific pump device, like I showed earlier. There are many manufacturers of that, and it acts both as a basal and a bolus insulin. I'm sure that we'll probably think about it, that how can rapid-acting insulin act as both basal and bolus insulin? Okay, but the answer is very simple. Don't forget that when we say that an insulin is basal and another one is prandial or mealtime insulin, is actually the rate at which they dissipate from the subcutaneous tissue that makes them act like that. The insulin that both of them relate into the blood actually look exactly the same. Okay, it's actually the difference is actually the way they act and the way they leave the subcutaneous tissue. Okay, but since we have something that can pace the delivery into the subcutaneous tissue here, that's the infusion device that's attached to the patient. So for a basal delivery, this insulin just goes. Oh, So just gradually and continuously, and that's the basal component, okay? But when the patient needs a surge, whether when the patient wants to eat or when the patient says that the glucose is high and I want this glucose to go down on time, the person can just program it from the device, and then you can get like a bolus component for it. So it's still the same insulin. So the indication for a continuous subcutaneous insulin infusion is the established indications are in patients with type 1 diabetes and also patients that are pregnant. So patients with type 1 diabetes, not all of them, but patients that you are not able to get a good on a basal bolus regime, in which there's intractable dawn phenomenon. Dawn phenomenon is a situation in which there's a more than usual surge of counter-regulatory hormones in the morning. So all of us, we actually have a little bit of surge of counter-regulatory hormones. That includes cortisol, growth hormone, and a bit of glucagon in the morning that leads to a bit of morning hyperglycemia. Okay, but it's not exaggerated in most people. In certain patients with diabetes, they have that surge, and so they can have early morning hyperglycemia. And so these people, if it's not amenable to other manipulation in treatment, the common manipulation in treatment we do for this is to shift the timing of the insulin. But if that's persistent, then a CSIR can counter that very well because of the adjustable flow rate of the basal insulin release. Okay. Also, in people with recurrent hypoglycemia in pregnancy, and in people with certain lifestyles that they actually need basal bolus insulin, but they cannot just really be injecting themselves at certain time because of the kind of work they do, or sometimes simply patient desire indications for the subcutaneous insulin infusion device. Okay, it requires a educated, motivated, and techy patient because it's quite technical. It requires some training, actually a lot of training, and frequent interaction with the healthcare team. Okay, but sadly, it's very expensive. The device, I know, costs more than 2 million naira if you convert it to naira. Also, there is risk of infection where the needle of the tube stays in the subcutaneous tissue, usually in the abdomen. Okay. Of course, some people cannot deal with the psychology of having something attached and connected to their body all the time. Some people cannot just really deal with that. Of course, there's the risk of diabetic ketoacidosis in case there's tubal blockage or kinking of the tube. And of course, it's a bit complex to use, even though for most people, once they get the hang of it, they actually really love it. Of course, it's not widely available in Nigeria. Most of the few ones I've seen were bought in from patients that were started on it from outside the country. Okay, so there are many. So we've talked about insulins, we've talked about the insulin regimens. We are talking now about the injection devices, the things we use to inject insulin, which I think we know this already. Okay, so there's a basic syringe and needle device. I'll show it in one of these slides down the line, which we all know. It's cheap and is widely available and is perhaps the most used. The study I quoted from Umar here earlier said that I think it was 99% of the patients with diabetes were still using needle and syringe. Sadly, it's more technically demanding. You have to know how to withdraw. You have to really know how to inject and hold the syringe and needle the way a doctor or a nurse should hold the syringe and needle. And oftentimes, when you tell the patient that you want to start them on insulin, that's what comes to their mind. They think of the syringe and needle. They think of, I'm not a healthcare worker now. I cannot be injecting insulin myself, okay? And that's actually one of the barriers to people starting insulin, okay? The needle and syringe also requires more dexterity. You have to actually be able to use your hand. It's not a problem for most young people, but if you imagine a 80-year-old person, a 70-year-old person, they may not have that dexterity. So imagine someone with rheumatoid arthritis or osteoarthritis of the hand, or with previous stroke. So many things can reduce dexterity, so that the fine movement you need to do to withdraw insulin in syringe and needle to 18 units or to 19 units, it actually takes a lot of dexterity. It requires good vision. There's proneness to errors because of this, okay? And I'm not sure how many of you have had this kind of challenges in the past, okay? But sometimes some people use the syringe for 40 units per mil rather than that of the 100 units per mil, or vice versa, which can cause erroneous doses of insulin to be administered. The pen device counters most of this. It solves most of this problem. almost all of this problem. And of course, apart from the pen devices in which you put the cartridges inside, we also have the pre-filled pens in which you don't even need to change, you don't need to swap the cartridges, and you just dispose the pen after use. Okay, so all of these have their pros and cons. Of course, I didn't fill in the cons for these pen devices, but obviously they are slightly more expensive than using a needle and syringe based device. Okay, so talking about injection technique, before insulin is administered for the first time, the pen insulins, one needs to actually, I've forgotten the word we use, but it's like a zero in it, such that any little hair in the cartridge is expelled, and the person does not inject air into the subcutaneous tissue. Not like injecting air into the subcutaneous tissue is dangerous to any, it's not really dangerous, not like into the blood vessels, but it will make them dose a wrong amount of insulin, and God forbid the injection actually went into a blood vessel. So that needs to be done. That's one. And then secondly, for insulin that are mixes, so for insulin that are pre-mixed, either mixed starch, Immunin 7030, Novomix, Humalog mix, they actually need to be resuspended. And resuspension is done by, like shown in this first A diagram, by rolling it just between the hands, so that because the particles can actually settle, the protaminated ones can actually settle, and if it's not resuspended like this, the right dose of insulin may not be injected. You may inject more 70 than 30 or more 30 than 70. And the same also goes for the insulin in vials. Once it's premixed, then it needs to be resuspended before you administer the insulin. And then, of course, in injecting insulin, the site is chosen. I don't think I have a picture on the site. Okay, but we all know that insulin is administered in the thigh, in the anterior abdominal wall, and on the outer part of the shoulder. It can also be administered, even though less commonly, on the outer parts of the buttock. Usually, when we are giving patients sites to inject insulin in, we should use sites that will be most convenient for the patients, knowing now that the injector is a self-injection, the person is injecting himself. And that makes injection around the gluteal area inconvenience. Even the outer upper arm is slightly inconvenient, and the most convenient area is usually the thigh or the anterior abdominal wall. Okay, so for the pen insulin, which usually comes with a shorter, it usually is injected at 90 degrees. Of course, usually when you're starting someone on an insulin pen, you should actually choose the length of needle that is appropriate for the thickness of the person's skin. Okay, we want it to just get into the subcutaneous tissue, not any deeper, but not even any, it should not be too outer. Okay, because if that's done, it can give insulin side problems, either pain in the muscle, either lumps, and the person will not likely be adherent to using that insulin. So we should find based on the skin thickness of the person. By the time you fold the skin, you'll be able to gauge the best depth, the best length of needle to give for the person. And then, so for most pen devices, it's injected at 90 degrees if you're able to get the length of pen. If you think the needle is too long, slightly too long for the person, then you have the person to slant it such that, based on Pythagoras theorem, that longer one will not get as deep as it should get. Okay, but for most insulin needle and syringe, you have to angle it at 45 degrees, so that you don't get into the muscular layer. So that's shown here for a needle and syringe based device, because most of those needles are longer than 8 millimeters. Okay, I think basically that it's also important to know that after injecting insulin, the site should not be rubbed. If there's any drop of blood or any liquid after it, it should just be dabbed. Okay, it should just be dabbed. It should not be rubbed. And of course, after injecting with a pen device, the patient should wait for at least 10 seconds before withdrawing the pen, because if it's withdrawn earlier than that, insulin can still be dripping out of the pen, and they will likely have underdosed themselves. Okay. So glucose monitoring is very important to monitor glucose levels in an in any patient with diabetes, but it's more important in an insulin treated patient. And of course, there are many reasons for monitoring the glucose. is very important for titrating the dose of insulin. The target dose of insulin is actually based on the blood glucose. It's a dose that controls the blood glucose that is the appropriate dose for that particular patient to use. Okay, so there's no universal dose of insulin. We talk about starting dose, okay, but there's no universal dose of insulin. And the intensity of monitoring should be proportional to the intensity of the regimen. So someone that is injecting more times a day will likely need to check more, and someone that is injecting fewer times a day will likely need to check less frequently. Okay, glucose monitoring is also one of the key strategies against hypoglycemia, because if the person is getting to normal, or the glucose is getting too low, or you're not knowing because you're not monitoring, then the person is at a higher risk of hypoglycemia. And that's why it is compulsory for insulin-treated patients to own a glucometer. They must own a glucometer, and they must be able to self-test, they must be able to interpret the readings, and they must be able to act based on the readings. Okay, and that's why if you discharge the patient, if you admitted the patient with hypoglycemic emergencies, for example, and you're discharging the patient on insulin regimen, either short-term or long-term, they actually have to own the glucometer and start using it on admission before they are discharged. That's the only way you can discharge them safely on insulin. It's not like they will get home before they are now buying the glucometer. That will not work. So they should be taught to self-test. They should be taught to interpret the readings, and usually, of course, they should do it. The diabetes educator on the ward should go through it with them. The actions they will take, readings like this, what it means, why it did that, how to interpret it, and that is actually key for patients on insulin therapy. Okay, so this talks about monitoring various regimens. Obviously, as I mentioned earlier, the frequency, the intensity of monitoring varies directly with the intensity of the therapy. Okay, so for patients, for meal-related regimens, for patients on basal and oral agents, okay, basal and oral agents example is someone on metformin, on downhill, and now also on Lantus, because metformin and downhill was not bringing the sugar to control. Okay, so such a person should be checking at least the fasting blood glucose, which is the best way to assess a basal insulin. Okay, the fasting blood glucose, don't forget I mentioned earlier that basal insulin mainly works by suppressing hepatic gluconeogenesis in the fasting state. Okay, so you assess your basal insulin with the fasting blood glucose. Okay, and occasionally the person should also still check the postprandial, because that's how you assess that the other oral agents are still working. If someone is on basal insulin and oral agents and the fasting is good, but the person is still having postprandial glucose surges, then it tells you that basal plus oral agents is not a viable strategy for that patient, and you need to go to either the basal plus I talked about earlier, or the patient goes to a twice daily biphasic insulin regimen. Okay, for someone on a twice daily biphasic insulin regimen, we monitor by checking the fasting and the before dinner. Okay, the evening insulin controls the fasting. Don't forget that that's where you have the intermediate acting one. So the evening insulin controls the fasting, and then the morning insulin dose controls the pre-dinner. Okay, and that's what we use to adjust it. Of course, the person should also check postprandial glucoses as well. Okay, whereas in people that are on basal plus bolus insulin regimen, that's the once daily basal insulin and then the before meal insulins. Those ones should check their fasting. They should also check before and after meals, and also at bedtime. By the time they've been checking for a while, it's often possible to skip some of these readings. When they skip some of these readings in our environment, it's often the pre that we skip sometimes, even though the pre is very much more important for people that do carbohydrate counting and adjust their insulin based on what they are going to eat and based on the ambient glucose level, that's the existing blood glucose level at the meal time. Okay, for people on continuous subcutaneous insulin infusion, they should check at least as frequently as people on basal bolus insulin. Okay, but if it's possible for them to get a continuous glucose monitor, which I'm not really going to go into in this presentation, but basically it's just like the continuous insulin infusion form that is worn on the patient. The continuous glucose monitor is like a monitor like that has a needle that goes in the subcutaneous tissue and continuously or intermittently checks the patient's blood glucose level. So in people on CSI, they have to check their blood glucose level in a manner similar to that of a patient on basal bolus insulin, or in a manner using a continuous glucose monitor. Okay, in patients that are on non-meal related insulin regimen, depending on the intensity of the regimen, they need to check at certain hourly intervals. Okay, so for people on basal and correctional insulin I mentioned earlier, they should check 6 to 8 hourly, after each check, a decision is made on whether to give a correctional dose and how much to give based on the kind of chart I showed you guys earlier. On patients on intravenous insulin infusion, they should check their blood sugars every 1 to 2 hours, and the trend of that is used to adjust the flow rate of the insulin infusion. Okay. On patients on GKI infusion, they should check the RBG 2 to 4 hourly, and the 2 to 4 hourly checks is used to determine the concentration of the next GKI infusion. If the glucose is within target, the concentration of the insulin in the GKI infusion is maintained. If it's above target, the insulin is stepped, and then of course if it's below target, the insulin dose, the insulin in the infusion is reduced. Okay, so briefly, I'll talk about barriers to insulin use. The slide is almost done. I'm sure it's less than 3 or 4 slides that is left. So let's just be patient. I know it's almost getting boring. Okay, but there are many barriers to insulin use. There are patient factors, there are the doctor factors, as me and you factor, and then of course there are the peculiarities of insulin regimen itself. We need to understand these factors so that we can. We need to understand these factors so that we can guard against it, and then it can guide us to take the necessary steps in making sure that insulin is used appropriately, and we don't hold back too much and deny patients of an essential medicine or essential therapy. So one of the patient factors is a sense of personal failure in not being able to control their blood glucose level with lifestyle diets and on oral treatment. So I'm sure it's a common situation for you to say that, for patients to say that, but I'm doing this now, but I'm not eating anything now, but I exercise every day, I do this, and they see it as a personal failure because they know of other people that have had diabetes perhaps longer than them, and they're not, the oral agent is still working and they are not requiring insulin therapy. So usually we need to educate patients that they are needing insulin is not because they fail personally. Diabetes is a progressive disorder, and the severity of that progression of the insulin resistance or impaired insulin secretion is variable in people, and it gets worse over time. And a good number of people with diabetes, with type 2 diabetes, will eventually require insulin. It's not because of what they did or what they did not do. Okay. They also have a perception that the diabetes is getting worse, which is true in some way. Okay. But usually I use the carrot approach for this. I go from the positive perspective that no, now we've made a decision to do something better to get the diabetes under better control. So you should actually be happy that we're going to do something to actually get this under control finally, because oftentimes many of such people have been going about the hyperglycemia for too long a time. Okay. Additionally, people get some apprehension and fears that insulin use is complex. Will I be able to do this? And many times it's often good to educate them that it's natural to feel like that when they're about to start insulin therapy. Young children use insulin therapy as young as 8, even 10 years old. People with type 1 diabetes self-inject, okay? And even very old people too are able to self-inject insulin. Once they understand it, they'll have some control over it, and usually they'll be happy with it. So if you reassure them with a few stories from a patient here or there, or with a fictitious patient sometimes, it reassures them and it gives them the confidence to go ahead. Of course, I'll still talk about some other things that can be used to reassure patients when they're going into insulin regimen. Okay, so there's a role of the social stigma or phobia. Okay, but thankfully, when a more modern Abuja is slightly more modern, and those should be less. Okay, and of course, we also should reduce such stigma by not making insulin sound like a bad thing, so to say. Okay, there are many doctors that have made insulin sound like a bad thing, like by using insulin to threaten the patient, or making insulin sound like a punishment, or a punishment for incompetency or for laziness, or because they were slack in applying their lifestyle medications. The truth is that there's nobody that can apply lifestyle medications 100%. That's the truth. We are all humans. Some people it's 50% they can do, it's 60% for some people, and we should not now make them feel like it's because they didn't do 100% that's why they're needing to progress to insulin. The other patients you have that are well controlled on oral agents, they're probably not doing lifestyle changes even as much as these patients that are needing to go into insulin. Some people genuinely have needle phobias, and there are ways to desensitize them from that, and giving them the confidence they need to use to inject the insulin. Okay, many times doctors don't have the skill to manage the insulin therapy, either to guide patients into it, to support patients into it, and all that. They may not have the skills, hence the need for this webinar. And also sometimes some people have the skill, but they just don't have the time or even the staff and other resources to educate and support patients with insulin therapy. The truth is that putting a patient on insulin therapy is going to task you more as a physician. You're going to need more time to counsel such a patient. You're going to need diabetes educators to support the patient. Such a patient who have more questions would utilize the healthcare system more. That's the truth, because they need more support, and we'll talk about that. Okay. Also, insulin is peculiar. He has his own issues too. The risk of hypoglycemia is perhaps higher than some of the other oral agents or injectable agents. Weight gain is real, and of course, there can be negative impacts on occupation and some lifestyle activity, particularly in countries where there are more regulations. For example, in some countries, including UK, if you are a diabetes patient and you are insulin treated, there are some more occupational restrictions. It's unlikely that you're able to work in certain works. Let me just put like that. Don't let me talk broadly. Okay, so that's there. So what are the things we need to do if we are starting a patient on insulin as an outpatient? The first thing here is to educate. Is very key. We need to explain to them the need and rationale for insulin, making sure that they get it right. I have like a few leaflets I give to patients that they actually have to go through it at 1, 2, or 3 visits so that it sinks into them. They understand the need and the rationale for the insulin. It's not because they did not do anything right or wrong, okay, but it's actually more because the diabetes is either a such type that is not likely to respond to oral agent, or at such a stage that oral agent alone is inadequate to control the glycemia of their diabetes. The patient should be taught to obtain their insulin, to store it, to administer it, and to adjust it. Okay, they should also be taught hypoglycemia recognition and how to manage hypoglycemia. It's often very helpful to give patients time to psychologically prepare for insulin therapy. I'm talking about patients with type 2 diabetes now. So if you have a patient with poorly controlled A1C now or poorly controlled fasting blood glucose, and you tell them that they need to start insulin, you can give them a few days to think about it. Perhaps you can check their glucose again on that day just to show them that you need this thing. So that time in preparing for it, in reading about it, giving them educational resources, YouTube links, can prepare them psychologically for the insulin, and actually they ease better into it like that. It's also important for a diabetic educator nurse to show insulin use, and there are extra dietary changes that has to be made in a patient that is going from oral agents to insulin, or that is starting insulin afresh, which a nutritionist needs to counsel such patients on. Okay, we know this, but I'm just using it to break the slide. So these are the common insulin syringe device that we know. One of them is a 50 units per mil pen. It's actually 40 that we see more often here, and 100. Okay, even though 100 is the standard one that we should use in Nigeria. So that's the common insulin syringe. But this is a pen device here, and the components, which consist of the pen device itself, the cap, the attachment points, is the insulin cartridge, and that's the insulin needle. And lastly, on the right side of my screen, we have the continuous subcutaneous insulin infusion device, okay, which is a battery operated device that is attached to the body of the user. And the insulin that goes into this insulin infusion pump is actually like a cartridge like this, even though it has its own cartridges. And I've mentioned earlier that it's only rapid acting insulins that are used in the CSII devices. Okay, so now that we're familiar with that, how do we store insulin? I know that this is often a topical issue in our clients, and oftentimes this is done wrong actually. So unused insulin, that is insulin that has not been opened, should be stored in the fridge between 2 and 8 degrees Celsius, and there it can last till the expiry date. Okay, insulin that we have started to use, that insulin is open or it has been punctured. For a vial, you know that insulin comes in vials and as cartridges. The cartridges are for the pen devices. The vials, the big vials, they are for the needle and syringe devices. So when I say vial now, I'm referring to the ones that are for the needle and syringes. Those ones can be stored in the refrigerator at 2 to 8 degrees Celsius, where it can last up to 3 months actually for the vials. Okay, it can also be stored in a controlled room temperature. Controlled room temperature means at room temperature, but not somewhere that is too hot, where it can last for up to a month. Okay, so it can be somewhere cool at the side of your table, just somewhere cool in the house, not somewhere, not like beside the window, for example, where there's direct sun rays coming in. Okay, so we can store like that, where it can last for up to a month. Okay, insulin pen devices or cartridges can also be stored like this third point, that can be stored in a controlled room temperature, where it can last for up to a month. Actually, insulin pen devices should not be stored in a refrigerator once you have started to use it. Okay, but if you have not started using it, then it should be in the refrigerator. So, but pen devices that is in use should preferably be stored in a room temperature. Okay, and it can last safely for 28 days. After 28 days, the recommendation, that's after a month in practice, the recommendation is that it should be discarded. And that is the key reason why insulin cartridges come as 300 units. Okay, they don't come longer than that. They could have made them longer, but they don't come longer than 300 units. And most people, their doses are at least 10 units on the average. Okay, if someone uses 10 units a day for 30 days, that's 300 units, and it shouldn't really last longer than a month. So complications of insulin therapy, I'm coming to a close now. It can cause pain at the site of injection. That can be avoided and really minimized by appropriate injection technique. If your patient complains of pain at injection site, please let them inject in your presence. Look at the needle they are using, look at their technique, see if they are injecting into the intradermal space or they're going into the muscle. They inject into the muscle, it will be painful. Okay, so look at the injection technique with their needle. Okay, so make sure that the technique is appropriate and the needle is appropriate for their skin thickness. And lipohypertrophy is also common, even though it's less common with the recombinant human insulin, and it's even less common with the insulin analogs. Allergic reactions are less common with the insulin we use these days. It used to be more common in the days of animal insulin. Insulin is an anabolic hormone and it can cause weight gain, especially if the person abandons lifestyle modification, abandons controlling his calories, because now I have insulin and I can just adjust my insulin dose to mop up whatever amount of sugar is in my body. The person will pay for it in weight gain. Okay, so when we are starting patients on insulin, we should encourage them to continue lifestyle modification, encourage them to still curtail their carbohydrates so that the amount of weight they gain will be very little or very minimal. In addition, we oftentimes continue metformin in patients with type 2 diabetes such that to maintain or to improve the insulin sensitivity, such that they need less amounts of insulin to be effective. Of course, hypoglycemia is a real risk in insulin therapy, and is perhaps one of the key reasons that many doctors are wary of using insulin. Perhaps they've had one experience or the other before. Okay, and this leads us to the next slide. So how can we reduce hypoglycemic risk in patients that we are starting on insulin? And this is one of the key reassuring points when we're starting patients on insulin. Usually you actually need to tell them about hypoglycemia risk, but immediately you mention that, you have to tell them the steps you have taken to reduce their risk of having hypoglycemia. Because frankly speaking, when you counsel the patients with type 2 diabetes about the risk and benefits of treatment, of course, you also counsel them about hypoglycemia, about their adrenergic symptoms and the central symptoms that they can have, and the fact that hypoglycemia can lead to seizures, coma, and also death. If you tell them that, most patients will like, no, doctor, you want to give me this? Are you sure? Okay. And you have to immediately you counsel them on hypoglycemia and its risk, and how to recognize it and how to treat them and how to treat hypoglycemia, you have to go next and tell them the measures you have taken to reduce their risk of having hypoglycemia. Okay, so the things we do to reduce hypoglycemia is to make sure that number one, that does this person really need the insulin? Is there a need for insulin here? Does it make sense? So that's one. And then secondly, you have to make sure that the regimen that you are prescribing is the optimal regimen for the patient. You're choosing a regimen based on efficacy, based on safety as well. Okay, so someone that needs just a basal insulin, I won't go ahead and prescribe a basal bolus insulin regimen for the person. Someone that just needs someone that needs a twice daily insulin, I won't just put the person on just a basal insulin and just be adjusting the dose upwards, whereas I should have shifted to a twice daily biphasic insulin. So make sure that you are choosing the best regimen and choose the safer insulin for the patient. So for example, if I want to reduce the risk of nighttime hypoglycemia now, I will prefer to go with a basal insulin like insulin glargine or insulin glutamine rather than prescribing MPH insulin, for example, to reduce the risk of nocturnal hypoglycemia. If I want to reduce risk of hypoglycemia during the day, I can choose to use insulin analogs like Lispro or Aspart rather than using soluble insulin, which you have for a longer period. Okay, so I'll choose my insulin wisely like that to reduce the risk of hypoglycemia. Also, in choosing the starting dose of insulin, it's good to start small and escalate gradually. Okay, so start small and escalate gradually. I mentioned earlier that when we are adjusting basal insulin, for example, we should wait for 3 to 5 days and see the trend of the glucose before we make adjustments. It's not like you're starting today, adjusting the next day, adjusting very fast. All those things can slightly increase the risk of hypoglycemia. So it's important to take these measures and also discuss them with the patient. Also, if you counsel your patients very well about using insulin, you teach them well, you counsel them about hypoglycemia, how to recognize it early and what to do, it greatly reduces the risk of hypoglycemia, of severe hypoglycemia anyway. And of course, you should provide the patient with resources online or some literature on insulin therapy and how to reduce hypoglycemic risk. Those information usually really reassures them, okay? And will reassure you as a physician as well. Also, it's important to give live support to patients with diabetes that are being insulin treated. Live support means the number of the diabetes nurse or diabetes educator that they can call if they have issue, or basically the things they can do to, if they have any issue at any particular time, there's someone they can reach out to and can give them guidance on what to do at that time, okay? In certain places, they have the Diabetes Association, among which some of them have subsets, either the insulin-treated one or the ones with type 1 diabetes, and they can reach out to themselves and they can get information on what to do in certain situations. So giving that support system makes the patients know that, okay, I'm not alone in this. If I run into any trouble, I can always reach out here and there and get the answers I need, okay? We should also be able to identify the patients that are high risk for hypoglycemia, okay? So patients that are leaner, patients that either use alcohol excessively, patients that have renal impairment, kidney issues, patients that have a very poor appetite or have an unpredictable eating pattern are all at a high risk for hypoglycemia. And such people, you would you'll be more inclined to choose the safer insulins, and those are the analogs and the basal insulins, like I mentioned. You'll be more inclined to start at even a smaller dose. You'll be more inclined to monitor even more frequently and more frequent reviews for those kind of patients. So those are all important measures we can take to reduce the risk of severe hypoglycemia among patients that are being started on insulin, okay? So I think that's basically. I will conclude by saying that despite the expanded range of medications we have now available to treat diabetes, insulin therapy still remains a critical component of diabetes care in this age and time. And a clear understanding of the use of insulin among us clinicians will promote a safe and appropriate use of insulin while offering adequate support to patients so as to achieve optimal outcomes. Okay, so these are some of my references. The other ones are quoted in slide. Thank you very much.
Thank you very much, Dr. Awofisoye. That was a professorial lecture. very detailed. I'm sure everyone, will need to rewatch it again to get the full. I've posted on the chat the YouTube channel. On the YouTube channel, if you go on YouTube and you search for Limi Hospital Network, you will see all the different webinars that we have been holding. They are all there for answering so that you can watch again and get the best out of it. Also, I said you need to send emails if you need to get the CMEs with your necessary information. So we'll take some questions now. What category is Lantus pen and what is the usual dosage?
So Lantus pen is a basal insulin. Okay, I mentioned earlier that insulins don't have usual dosage, but we have initiation dose, that's a starting dose. Okay, so the starting dose of Lantus is typically about 0.2 units per kilograms per day. Okay, so someone that weighs about 100 kilos, if you say 0.2 units, will be around 20 units per kg per day. So that's Lantus insulin is a basal insulin, that's a background insulin, and that's the usual starting dose. Yes, I mentioned protamine. Well, no, it's not like the warfarin antidotes. I can't remember the full name of the warfarin antidote now, but there's a protein called protamine anyway, and that protein is part of the things that is used to make insulin come together. That's precipitate in the subcutaneous tissue, and it's to now act for a longer period of time. So any insulin that is protaminated will be converted. It's converted already to an intermediate acting, so it will act for a longer period of time. So that's the protamination.
Oh, okay. What role does insulin play in diabetes who are fasting? What role does insulin play in diabetes who are fasting?
Okay, so for patients with diabetes who are fasting, obviously their insulin regime or their insulin structure should be revised at the beginning of fasting for that fasting period. Okay, and patients that are on insulin already, usually, of course, if they needed insulin before fasting, usually they will need to continue the insulin during fasting period. So it depends on the regime. So for example, someone on basal bolus insulin, the basal dose of insulin will not change. Sometimes it may need to be reduced by about 30%, but most times will not change. Okay, but the dose of the bolus insulin that will now be used before SAO and the HIFTA usually will be reduced significantly. So that's that part. Okay, but for patients on premixed insulin, usually because many people with diabetes that fast often take less food in the morning, very little food in the morning, and that's at SARI time, and then they take more in the evening. So oftentimes we reverse the doses of the insulin and place the former evening dose, which is usually the smaller one before SARI, and then we use the larger dose before the HIFTA in the evening. Okay, but almost always patients with diabetes should be reviewed before fasting, and it's especially so in people that are insulin treated.
Okay, Dr. Anuniru says, I have seen instances where in resource-limited settings, the conventional hypodermic syringe was used to give insulin instead of the conventional 100 IU insulin syringe. What do you think about this? Is the estimation of those normal syringe, that's hypodermic syringe we use, in any way accurate?
It's actually very impossible for it to be accurate. It's not possible. It's not possible. Because it's not possible. It's not possible. Even with a 2 ml syringe, it can't be accurate. So it can't be accurate. It can't be accurate. I know that we're in Nigeria and things happen, but it can't be accurate. Okay, but I know we can be in difficult situations sometimes.
All right. So Dr. Aniniru, sorry, if you're in a difficult situation where you're in a difficult situation, but call for help, and you should try and get as much as possible, make use with the standard thing. Okay. There was a question sent in via email before we started. Sorry, just a minute. Okay. How, by Patrick Adumbiola, how soon should insulin doses be adjusted after initial commencement? How soon should be?
It depends on the clinical settings now. If we are talking about an outpatient settings in which the patient is stable, etc., usually it should be adjusted after every 3 to 5 days. We should wait for at least 3 to 5 days before an adjustment is made. And that's so that we are not working only based on one single glucose or two glucose values. By the time you have 3 to 5, you have a trend and you can see where the glucose is really at, and we can adjust with that. So that's one. Whereas, of course, in inpatients that are being treated for either insulin infusion or GKI, we usually need to address that. Even within a few hours, we make adjustments because we need to get the glucose down within a short time. Okay, but for outpatients, within 3 to 5 days is okay. And actually, it's okay to tell the patients that to write on the paper the adjustment the patients should make based on some predefined algorithms so that they can make some adjustments themselves even before their next clinic visits.
Okay, so diabetes education is a very key part of insulin therapy. You need to educate the patients as well as sometimes a lot of patients have to adjust it by themselves even before they come to the clinic. It's very important that you educate the patients very well when starting diabetic medication. Then the person has a second question is, which is the best insulin for patients with normal fasting glucose levels but higher postprandial levels? I think. Go ahead.
So patient with that kind of profile depending on how normal if fasting is truly normal. Some patients would actually need just a prandial insulin, that's a mealtime insulin, without needing a basal insulin at all. So some people can either just have soluble before their meals or have a rapid-acting insulin like Novorapid, that's Aspart or Lispro before their meals without using a soluble at all. Now, for such patients, if they still need some basal insulin, which most people will, we might err on the side of a premixed insulin with a higher pre-meal component. Okay, so instead of using 30-70, for example, in such a person, if I'm going to use a premixed insulin, I'll opt for 50-50, in which the proportion of the pre-meal insulin component or the meal responsive component there is higher. So those are the two options for such a patient in which is a predominantly after food high sugars that they have.
Okay. The next question, let me see. Dr. Musa Peter O'Malley, I think that's a cardiologist. If a patient on insulin decides to use alcohol, what is needed? What is the needed adjustment to reduce risk of harm? Alcohol in a patient on insulin, what can they do to reduce the risk of harm?
Thank you very much for that question. I actually should have mentioned it. Okay, so for patients on insulin that take alcohol, just the steps to be taken is to, number one, it's better to eat before taking the alcohol, because alcohol, diabetes, and insulin can increase the risk of low sugar. So better to eat before the alcohol, and then depending on the insulin regimen, it's good to check the insulin too before the alcohol period. And any pre-meal insulin before that alcohol time should probably be reduced to some extent. So I'll use example of someone on a basal bolus regimen, that's 3 times before meals and then my lactose at night. So if I want to take alcohol, maybe after my dinner time, I should not just take alcohol, I should eat before the alcohol time. Then I should take my insulin before that food, or I should reduce the insulin. If I know I'm going to take alcohol after, I should reduce insulin to some extent, perhaps like 20 to 30% before that time. And it's important to check at those times, importantly. So that's the adjustment that will be made for that. But for someone on just basal insulin, that's nighttime insulin only. If the person just takes the precaution of eating before taking the alcohol, the person can take the once daily basal insulin as usual. So eating before the alcohol, I think, is the most important lesson for people who have diabetes and also use alcohol.
Okay. Thanks for the presentation. Are there diet restrictions for diabetes? Are there types of meals to be avoided, or anything can be eaten when you're on insulin? That's, you're starting insulin, why don't you just enjoy your life and adjust your insulin to meet what you're eating?
So nobody should just eat anything. Basically, I will tell people that the dietary controls that are existing before the person was started on insulin should also be continued. after the person has been started on the insulin. Okay, but there's a caveat to that. The caveat to that is in, number one, in adolescents that are growing, we encourage them to eat more. And apart from the ones that are obese, we try not to put them on any very serious dietary restrictions. Otherwise, we might compromise their growth and we might compromise puberty. So that's one. Secondly, are people that are lean or perhaps underweight from the effects of diabetes, or perhaps again underweight from the effects of very long time of trying not to start insulin and not only eating vegetables because they don't want their sugar to go up, and they end up losing a lot of weight. So for those people, we need to relax restrictions and making sure that their diet is balanced, healthy, and contains just the right amount of calories that they need. And if we need to adjust the insulin to match these calories, we should do that so that those kind of people can attain a healthy body weight. I hope that answers the question.
Okay, so I think that answers all the questions. I cannot see. Okay, what factors determine? Okay, for gestational diabetes, Dr. Okeke, consultant obstetrician, is asking, what factors determine the choice of treatment in gestational diabetes mellitus, insulin or metformin?
That's a very great question. It doesn't have a straightforward answer, unfortunately. Okay, so number one is that metformin is being increasingly used among patients with GDM in some settings. Actually, in a lot of settings, they are still wary of using metformin in GDM, and some settings they actually don't consider it as a first-line treatment. A lot of settings there, even in Nigeria and especially in the US. Okay, but in the UK and many other European countries, metformin is frequently used more and more as a first-line treatment in GDM. Okay, but it is said, based on the nice guidelines and UK recommendations, if the postprandial blood glucose, that's after meal blood glucose in someone with GDM, if they are eating if they're eating above 140, I'm not sure of the conversion for that. If they're getting more than 140 postprandial, then the person would likely should go to insulin straight rather than trying just metformin. So that's one. Secondly, of course, is that anybody that will place on oral agent on metformin, on a reasonable dose of metformin, usually 500 milligrams twice a day, and they're not meeting their targets within 2 weeks of diet and oral agents, usually we need to escalate to insulin. That's two. And then thirdly, based on the A1C, by the time the A1C is in the diabetic diagnostic range, we remember that even though HbA1c is not, even though HbA1c should not be the main way to diagnose GDM, okay, but HbA1c, of course, is artifactually reduced in pregnancy, and that means the cutoff is lower. So in most people in which you have a HbA1c of greater than 6.5 in pregnancy with GDM, it's better to go straight to insulin rather than dilly-dallying with metformin, which will just basically lose time. So a PPBG, I'm not talking OGTT, postprandial blood glucose based on their checks. If you're getting more than 140 after meals, and we know that the target is less than 125 or 120, depending on the guidelines, which guidelines we're using, usually they will need insulin to attain that. So that's the way I'll answer that question. But it's not a very straightforward situation. Many times it's actually just a watchful watching with using metformin, and if metformin is now not getting them to target, to start the insulin. Okay, but if the postprandial is already above 140 by the time we're starting, it's probably better to go straight to insulin. Or if they have pregnancy threats or complications already. Okay, so threats or complications, for example, if they have some GDM complications already, like polyhydramnios, or baby is already getting large, or they're already late in pregnancy where most of the weight gain starts, it's better to go straight to insulin at that time. Thank you very much, sir.
All right, Dr. Aliko, do you have anything to add? Okay, so I will just round up. With a few announcements. I'll just round up with these announcements. So every Friday by 3 p.m., essentially Limi Hospitals and Cardiocare Hospitals, so Limi Hospital, Limi Children's Hospital, and Cardiocare Specialty Hospital here in Abuja we have opted to give of what we have to the general medical public. So we want you to help us share, invite other people, put it on your Facebook timeline. When you see the adverts, put them all around. We want as many people to learn. I'm sure you have been thoroughly enriched by this presentation. And we want this information to go around. We want patients to get better because doctors know better. We believe strongly that if we know better, we will do better. And we think that Nigeria can get better if we know better. So you can watch all the presentations, including this one will be there by this evening or tomorrow on YouTube. Just check for Living Hospitals Network on YouTube, and you can get these presentations there. People that were not able to attend this webinar can still attend the webinar at any time. They just have to log in with the Zoom password with the same credentials, and it will be there. And then if you go on any of our Facebook pages or Instagram pages, you can rewatch it. This one is already broadcasting on Facebook, so you can rewatch if you miss some parts of it at your own leisure. If for doctors that need CME points, send your mail with full name to cardiocare@gmail.com. We'll try to verify your attendance by the amount of time that you were here. For people that just peeped in for 2 minutes and logged out, we probably will just ask you a few questions based on what we learned and send you to YouTube. Once you can answer the questions and you're able to, once you watch the video, you're able to answer the questions, we'll give it the same. Because the idea for us is that you get the knowledge and not necessarily the certificate. Okay, so the certificate will be sent to your email. Living Children's Hospital is one of the people that sponsor this, and they have a transport incubator. We actually go to labor rooms and theaters around the city. So if you are delivering a preterm baby, a preterm unit, 24 weeks, 25 weeks, call ahead, and then somebody will get our team to go there to resuscitate and then pick up the baby straight to our NICU. So the baby actually can get inside an incubator within minutes of being born after necessary incubation. And that's Living Children's Hospital in Wuse too. That's what it looks like. Cardiocare in Gariki Area 11 essentially is a world-class facility. It's a center of excellence. So we do clinical and interventional cardiology there. That's what we do essentially. Endocrinology and diabetology, as was talked about, neurology, nephrology, and dialysis, all of that is taken care of. So you can refer your patients when there are times when you should refer. So we are giving information that's for what you can do before you refer, but there are times when you are not sure and you may need a consultant. So we have a very robust practice here, essentially focused on internal medicine, nephrology, dialysis, intensive care, and we also do a lot of interventional cardiology. That is cath labs, for angiographies, for heart attacks, for people that need pacemakers, CRT devices, essentially everything heart. This is how, this is the interior of the facility. This is the waiting area for patients when they're waiting for their loved ones. Essentially, we also, I said we do a cath lab. So whenever the person is having a blocked artery, we'll try and fix it in the cath lab within 60 minutes, patient getting in. And we also implant heart devices in our cath lab. You know, whenever the heartbeat is uncoordinated or slow, we also do electrophysiology studies when we want to ablate abnormal pathways. And essentially, it's done a week without open surgery. So the patient can be out and go home within 6 hours or 8 hours. So we pass wires into the patient's groin, just like this. You can see in this slide. Once we just locate the femoral artery or the radial artery, then we pass wires and we do everything through the wires with the patient still awake. This is what our cath lab looks like with all the screens and all the gadgets all over the place. For example, this is a patient with diabetes that was rushed in, referred from a federal institution here in Abuja, was rushed in. Patient was told to have diabetes 2 weeks earlier, 41 years old. Blood sugar was 340 milligrams per DL at presentation. Essentially what we did is essentially what was discussed in the case scenario, which is put him on insulin infusion and then take him straight into the cath lab. So it was the cath lab within 90 minutes, and then we opened up the artery, and you can see the blockage of the artery there. For those people that cannot take note of that, you can see the blockage of the artery there. So you can see that at some point in time, the blood flow is flowing better, and then is blocked right there. Okay, so the people that referred also had already suggested that it's likely going to be LAD, and that's essentially what happened. And then we opened up that blood vessel there. So that's what it looks like. So this is not a blocked LAD, and this is how we put in devices. These are two leads for device, and we're about to put the third lead for a CRT device that is needed. So every Friday by 3 p.m., and these are the same guidelines. So cardiology is what we do. We also do endocrinology. So all aspects of cardiology, interventional, clinical, echoes, stress, holters, everything. Cardiac biomarkers, CCU, arterial blood gases, and all that. Endocrinology, diabetology, Dr. Awofisoye leads the team of endocrinologists to take care of diabetes. So we have such patients you may need to refer. And Dr. This is the key team of neurologists for vascular neurology, strokes, seizures, movement disorders, EEG. And nephrology is also there. We do a deal of dialysis. This is what our intensive care unit looks like. This is our high dependency unit actually. So when patients are very sick, like we talked about diabetes, we mount the infusion, the IV infusions, and the nurse is here to monitor it. The blood pressure monitors there, the monitors there measure invasive blood pressure. So we are seeing the blood pressure actually in the artery, not just outside, and then we can have continuous glucose monitoring as well. We also do complex internal medicine, and essentially everything is sponsored by Limit Hospitals. So it's world-class healthcare at your doorstep. Essentially, that is us. So next week, Friday, we will be going on to discuss other things. I would like to ask what topic, I would like to take a poll of what topic you want to be discussed from any aspect of medicine. So from internal medicine, O&G, pediatrics, a lot of people, there was a lot of very fantastic response for the pediatrics as well last week. So if you have any suggestions as to the topic you want to hear, we will choose the most prevalent one that people want us to discuss very, very much. So you can put it in the chat box, or you can send it in mail, cardiocare@gmail.com. So any topic that you particularly want to hear, just put it in the chat box, and then we'll likely focus on that for next week. Barring that, we'll choose a topic and we'll communicate to you via email, inviting you. Thank you once again for joining us. If there are any outstanding questions, I think we've answered all the questions. Okay, Dr. Officer, do you have any final comments that you want to add or anything? I know it has been a very long and detailed lecture. What we'll try and do is we'll try and prepare some kind of algorithm, some simple 2-pager that can help you remember the key facts of starting insulin or how to use insulin, so that you can easily use that. Somebody's asking management of viral hepatitis. Okay, that's good. Somebody asked for nephrology. Okay, nephrology, thank you. Okay, we'll think about that. So nephrology topics are there. Management of viral hepatitis. Yeah, that's a very good one. Hepatitis is a very good one. Any other topics you want us to discuss, you can just put in the chat box so that we can consider it. Yes, and I want to appreciate those that have sent in emails appreciating us, or have just written thank you in the chat box. It's quite beneficial. We appreciate that so much. Thank you for thanking us. Sometimes doing this thing is not as easy as it looks, and some people are not very courteous or appreciative. They send rough emails, but we're very happy to those that encourage us with thanks. Professor Akinwusi, other senior consultants who have sent in messages, encouraging us to continue, because at some point in time we get a little bit tired. Okay, and that person says I also like viral hepatitis. So viral hepatitis is coming up more and more and more. Okay, so we'll look at that as well. So if you have any other topics that you want, you can just send to the mail. So for now, viral hepatitis is the leading topic that people want to be discussed. So we'll consider that very strongly. Okay. Thank you so much. All right, so we're ending the webinar right now. God bless you all. Thank you for joining us. We wish you very safe practice. Please stay safe. Keep on your face mask. Don't assume Management of asthmatic patients. Asthma, okay, very fantastic. I love that topic. If it's asthma, I would love to give that topic myself. Management of asthma, that's a very good topic. I want to remind everyone to stay safe. Keep your hands clean. Keep your face and your nose covered. And if you're not feeling fine, get to the hospital. Report yourself quick and get a test quick. Most of the reasons why I feel that healthcare workers have been affected the most is because when they feel topics, when they feel symptoms, they shrug it off. They find other explanations for it until they present very late. So if you feel funny, get yourself. And then if you have patients you are not sure of, refer to the appropriate people. Cardiocare is always here to assist. You can also assist via phone calls or otherwise. Okay. And that person says viral hepatitis. I think Dr. Awofisoye, Dr. Olaleko, viral hepatitis is leading the pool for now. Viral hepatitis is leading the pool for now. So I think we might likely move over to that, Dr. Kehinde as well, and then asthma, and then somebody asked for something in nephrology. Okay, thank you very much. We'll be ending the webinar right now. God bless you all. Stay safe. Bye.